Good morning, everyone. There is a handout. It's going to be passed on to you. This handout is supposed to help you to understand your weaknesses. Mostly are multiple choice questions. So there is one mistake in it because last night I found out that Joint Commission removed the annual mandatory training. So question 34, I believe, is just delete that question. The rest of the questions are okay. How you move the next slide? Where is the, oh, here it is. What we're going to discuss definitions, Alaro principle. Anyone knows what Alaro stands for? What's R stands for? Reasonable. Don't forget, this is a very, very important. Monitoring, we want to know if you get pregnant and you have to work, what's your rights? Well, how do we measure fetal monitoring? Radiation protection principle. Anyone know what's the definition, basic fundamental of radiation protection? Time, distance, and shielding, right? The use of shielding in Cath lab, we'll discuss it. Verification of your lead eyeglasses. There might be lead eyeglasses that you find in the internet that they are not lead in it at all. So we'll show you how to check it. New NCRP 160, NCRP 102. These are all important for you. Recommendation on tissue reaction and the latest information. How to reduce the patient dose. That's extremely important. We'll show you how to do it. And also Joint Commission requirements. So we're going to try to cover all of this. First of all, before we do anything, definition. RADS, REM, and sievert. You all know this definition. So if I have, let's say, RADS, right? Imagine that this is the radiation, comes and hits my tissue. So this is energy deposit per unit of mass. They call it RAD, radiation absorbed dose, right? So when you take RAD and you multiply it by the quality factor, then it becomes REM. So this is in United States units, REM and RADs. In other part of the world, they use Gray and sievert. So if you ever have to convert from one to another, remember, factor of 100. International unit is 100 times bigger than American unit, right? So 1 Gray is 100 RADs, 1 sievert is 100 REM. The same way with millisievert and milligray, so on and so on. Any question about that? Because this might come in your exam. Typical exposure, you should know roughly what kind of radiation exposure you give to different people. So if you get a long radiography, you get 20 millirem. If you get dental, it's about 300 millirem. If CT is about 3,000 millirem or 3 rem. Average annual to a nurse in a hospital is 70 millirem. A flight from New York to Philippines is 13 millirem. So these are the typical exposure that we get on a daily basis for different type of work. On the other hand, a different type of work, you get different type of radiation exposure from. If you work in a waste disposal burial, you get 1.24 rem per year. If you work as a pilot, you get 700 millirem per year. If you work in a medical center, you get 70 millirem per year. So someone tell me why a pilot gets 10 times more than a nurse in a hospital. Can anybody tell me why? What's in his job or his job that gives him 10 times more radiation? Right? The more higher you go, the more background radiation is higher. Now, NCRP 93, published 1987, says that what's a typical American gets in 1 year. They call it average background radiation. And it was about 360 millirem. That was 1987. Still some publications, some places, they use this number. In 2009, they published the new one, 160, and this background radiation now is 620. So average American is get twice as much as they used to get 30 years ago. What changed? These are the changes that you see. You see now CAT scan, you see nuclear medicine, you see interventional fluoroscopy. These are the changes that makes average American gets more radiation annually. How much radiation you get in a Cath lab? So if you look at this is a very important slide. This is the beam that goes from here to here, right? Straight. The scatter is 90 degrees, right? So on top of the bed, it's about 3,000 millirem per minute. At 1 meter becomes 3 millirem per minute. So it's a factor of 1,000 reduced at the distance of this about 3 feet. At 6 feet, it will go almost less than 1 millirem, and so on and so on. So remember, distance is your best friend to reduce your exposure in a cath lab. How do we monitor you? We have this radiation dosimeter, you've seen it. This dosimeter, it tells you what institution, what department, which type of badge, what's your name, which period to be used. The threshold is 1 millirem. It's very sensitive. If I put one of them on the wall, in this wall, and I come back 2 weeks from now, it shows me how much radiation is in this room. So it's extremely sensitive. We have also ring badge for those people that they have to put their hands inside the beam. How to use the radiation badge? So obviously exchange dosimeter on time. You must return at the end of the month. Don't share it with someone else. Don't take it home. Do not use it in another institution. If you work in 2 hospitals, you have to have 2 different badges for each hospital. Can anyone tell me why? If something goes wrong and you have a high reading, how would I know where did it happen? So you must have separate badges. Store your badge in a free radiation area. How much radiation you are allowed to get annually by law? Whole body, which is under the apron, is 5,000. Any organ, 50,000. Lens of eye, 15,000. Your skin is 50,000. Lifetime, you take your age and you multiply it by 1,000 millirem. So if you are 40 years old, up to 40 years old, you are allowed to get 40,000 millirem. Is that clear? Now, let me ask a question. As fluoroscopy operator, which one of these is most important to you? Which one of these you have to watch on a daily basis? Anyone? Which one of these you might exceed, you come close to it? Lens of eye. So it's extremely important because your whole body is under the lead apron, but you sometimes bend on the beam. So lens of eye is extremely important. You have to have lead eye glasses. If you are a cath lab physician and fluoroscopy operator, but you get pregnant, all you have to do, declare it. It's not mandatory, it's voluntary. Declaration is in writing. You just write down, I am pregnant as of this date. Then we issue a badge for the fetus separately. And the fetus cannot get more than 500 millirem in 9 months or 50 millirem in any month. So they usually ask this question in the exam if you need to know. At the end of the year, you are supposed to get Form 5, which they call it annual exposure. So if you go to any institution and you work with radiation, that institution has to give you how much radiation you received last year. Okay? ALARA stands for as low as reasonably achievable. So there are some areas that might be practical. So they use the word reasonably. So you have to be reasonable how to get it as low as possible. How do we implement ALARA? We have level 1 and level 2. Level 1 is about 10% of annual limit in 3 months. Level 2 is 30% of annual limit in 3 months. His change is to certain numbers. If you get a letter, usually the institution send you a letter, hey, you have exceeded your allora level 1 in the last quarter. That notification. If you see someone comes and investigate you, you have exceeded allora level 2. That's investigation. You follow me? So they have to do two types of work. If it's allora level 1, your exposure, then you get notified. If it's allora level 2, you get investigated. Different type of exposure for fluoroscopy procedure gives you different types of exposure. And these are the types of procedure: neck, lens of eye, hands. And you see this is the effective dose. Effective dose, that means that they have considered it's extremely important for you to know how much radiation you get on the average for different type of procedure. So this is very important. There are two types there are two methods of effective dose calculation. One is some institution, they give you one badge outside the apron around your neck. Some institution, they give you two badges, one outside the apron, one under the apron. And they calculate from any of these two situations what should be your effective dose. We tried very hard and we used this method in other institutions. And unfortunately, the physician, they switch these two badges and the whole thing goes wrong. So we prefer this one, which is one badge outside the apron, and we calculate how much would be under your apron from that badge, which is pretty much has advantages and disadvantages. Right now, we used to do 0.3 times color badge, but now we have changed it, so this is now much better accurate. So the two dosimeter, we don't use it. Scatter is important. You have to know if you want to reduce the scatter radiation to your eye, you must be in this situation, not in this situation, which is try to put the tube on the other side of the table, not to your side. You follow me? Lead eyeglasses, as I said, it usually has around 0.75 millimeter, 98% reduction of those, and they are very similar in the market. Some of them, they have lead, some of them, they don't have lead. But this is $15, this is $200. So if you see something is too cheap, check it. Well, how do you check it? You put it under the fluoro, and you will see this one has lead, this one doesn't have lead. Is that clear? Now, in a typical Cath lab, you see that they have image intensifier, right? So you have this shielding here, number B. This is the image intensifier on the top. You have also shielding protection, which is this lead skirt, right? So use all of these that is available in the room for you. These are different type of protection devices. It's very expensive, supposed to come from the ceiling and wrap around you so you don't feel the heaviness on your back. These are the default one because it's mobile. Joint Commission in 2011 published a statement that says that recording the dose to the patient is important. So you have to, by law, you have to know how much radiation you gave to this patient. Now, how do they want it? They want it in a retrievable format. What does it mean? Joint Commission might come to you and say, okay, pick up a chart and say this patient was treated 6 months ago. Show me how much radiation you gave to this patient. And you have to be able to dig out those information. 99% of the fluoroscopy machine does it automatically. That means the data goes to the PACS system. But sometimes your machine is too old, so it might not be able to do it, so you have to write it by hand. At the end of the day, the physician is responsible, so make sure of that. There are something available in the market, they call it Dosimeter, so this pretty much captures the data if your machine doesn't do it. Protective patient drapes, these are available that you could buy it. Is 12 times reduce the dose to reduction, eye dose, and is 29 times hand dose. So these are effective, cheap, but it adds up if you could afford it. There was a publication from ICRP. ICRP stands for International Commission on Radiation Protection, and they said that they used to think that cataract happens at 2 gray, 200 rads. Now they believe it's 50 rads. So the limit of cataract to the eye, they believe, is lower. Has any of you ever exceeded 50 rads in any year? I have not seen it. The maximum that we have seen in the highest doctors that they work 12 hours a day with fluoro, they get like 10, 15 rads per year. So it never exceeds the limit. ICRP also has some changes. In the United States, still you are allowed to get 15,000 milligram to your eye, according to the law, regulation. But they are proposing to change it to 2 or 2,000 per year, average over 5 years, not exceeding 5,000 in any year. Do you follow me? So this is proposed. They have not changed it. They changed it in London and Europe recently to this limit for the eye. But United States still is 15,000 per year to the eye. Sentinel event. If you're treating a patient and this patient gets more than 15 gray to the skin, you have to report it. That's requirement. Besides, you don't want to exceed that limit. Can anybody tell me why? If a patient gets 15 gray to the skin, what do you expect? Anyone? Right? So you have to be aware that your foot on top of the pedal should be just touching it, tapping it, not just put it forever. You follow me? NCRP 102 has recommendation. It says only people that they need to be in the room, they should be in the room. If you need to be in the room, you have to have lead apron, lead gloves, whatever you need. You should stand behind the lead barrier if possible, and the lead apron should be 0.25 millimeter lead equivalent. Anybody knows why they call it lead equivalent? Is there anything outside that is not lead? Yes, there are. They call it composite material. It's 25%, 20% lighter than lead, but does give the same attenuation as lead. But if you fold it, it breaks. That's the drawback of it. So you could use anyone you prefer. Lead apron has to be checked once a year by your institution. That's the lead equivalent. If you dispose it, you have to make sure that you have a piece of paper that you disposed it properly. Because according to the EPA regulation and local regulation, lead is a hazardous material. So you cannot take the lead apron and throw it in the regular garbage. You follow me? Usually you give it back to the company and the company gives you a new one. Radiation protection principle, as I mentioned, time, distance, and shielding. Now, this happened in 2007. A 53-year-old diabetes, he has a stent replacement, and on the way back to Thailand, he had a chest pain, and he had so another second stent. So he returned to East Asia Hospital for 5 hours of fluoroscopy. Obviously, that was a complicated case, and you could see that radiation damage is obvious, right? Can anybody know what's the white stuff? Because the burning is so painful that you have to have some medication to reduce the pain. This was another case that happened in 2000, I believe, I forgot, 8 or 7, but this was 2000, 4-year-old male, and this is after 4 to 6 weeks. Then you see it disappears after 21 weeks, and then it comes back again after 21 months. And then you see the necrosis, and after a lot of skin graft of and surgery, the patient is helped. So if you are this patient, would you make a lawsuit against the physician? So as a physician, how do you prevent this? Before the patient comes to you, I have a slide. You check, you ask, have you had any stent? Have you had any fluoroscopy procedure? So you have to, this is the way you do it. Before, you check with the physician, with the patient, and you say, okay, during the procedure, you see how much fluoro time you give, right? You get estimate. Remember, if you exceed 1 hour of fluoro time, not operational time, if you exceed 1 hour of fluoro time, you are in trouble. You already have some reddening of the skin, right? And after that, after the patient goes home, you say, I want to see you in 2-3 weeks to make sure there is no reddening, there is no burning. Guideline, if I have to choose one slide out of all the slides I have in this today, this is the most important slide. How to reduce the patient dose. So pay attention, collimated X-ray beam as much as possible. Only step on the pedal when you necessary. Reduce the fluoroscopy time as much as possible. Use automatic brightest controls if it's possible. Set the default mode to low dose, not the high dose. The distance from X-ray tube to the patient should be maximized. For extended period type of procedure, move the angle so you do oblique to distribute the dose and minimize the use of boost mode in a high dose mode. So these are the technique that I suggest you strongly when you are alone, practice, and reduce, because Joint Commission and all the other type regulatory agencies that I know, they're gonna go after you because it's a lawsuit and they have to protect people. You are in the business of saving lives, but sometimes it's complication. So you have to watch how much fluoro you give to the patient. Yes. If it's possible, sometimes your machine doesn't give you that option. Follow me? But you have to see what the machine option gives you. My suggestion is sometimes put the phantom on the table and practice to see how you could reduce these dose to the patient. You could do it. Radiation biology, you have to have some background, a little bit of how much radiation is too much. First of all, there are two types of the effect. One is deterministic effect, one is a stochastic effect. Deterministic, that means I could calculate what's going to happen to the patient, right? This type of effect has threshold. Severity of effect is dose related, how much dose you gave. Blood count changes, cataract, erythema, epilation. These are all types of deterministic effect. LD 50-60, anybody knows what that means? Lethal dose that 50% of the people die in 60 days for human is 400 to 450 rem whole body. So it's about 4 to 5 gray, right? A stochastic effect is probability. It's increased with dose, no dose threshold. Severity of effect is not dose related. Cancer, genetic effect, all these are types of stochastic effects. So they might ask you which one of these effects are this effect, which one of these effect is this effect, to see if you know the type of effect. Remember, the way we calculate the risk to the patient is for cancer is about 0.05 for each sievert or 100 rem. Effect takes years to manifest for stochastic. Stochastic comes from statistic. It might happen, it might not happen. This is also important, additional. This is its skin, a single dose. These are the types of effect, how long it takes, how much dose you give, 2 gray, 7 gray, 20 gray, and how long it takes to see the effect or on the skin. The dose-associated acute radiation syndrome of whole body, This is all from ICRP 60. So these are the, what do you call it, area damage, and this is the dose, and this is how long it takes to see the damage. What causes cataract? There are many ways you could get a cataract. Diabetes, exposure to ultraviolet, use of a steroid. One of them is ionizing radiation, right? Do you worry about getting cataract from being a fluoroscopy operator? If you don't use your eyeglass, lead eyeglasses, then you should worry about it. If you do, I don't think you should be worried about it. What we know that radiation is a weak carcinogenic. We know probability of getting cancer is function of dose, how much radiation. No evidence of cancer below 10 rem or what's that, 0.1 sievert whole body. Also, I wanted to give you some risk expectancy. You know, anything you do in life gives you risk. If I cross the street from this side to the other side, I have a risk of getting hit by a car. So here, smoking one pack of cigarette, and if you are a male, you lose 2,400 days of your life. If you are a female, you lose 1,400 days of your life. If you work in a nuclear reactor and you get 1 rem per year, from 18 years of age to 65, you lose 51 days of your life. These are typical risks associated with the type of work. So working in a radiation environment doesn't mean that you're going to get cancer, but you have to do as low as possible. These are references. You could go and look at them if you want more information. As I said, the handout is for you to test your knowledge. Question number 34 is not valid because Joint Commission removed that requirement last night, so I didn't have time to remove that question from your handout. If you have any question, I'll be happy to answer now.